It's unusual to have the two master lecturers both be active members of SPA. And so I think it's just really a testament to the depth and the richness of our membership to have two such outstanding contributors to the field of personality assessment as we have with Aaron Pincus and Dr. Les Morey. I'm going to turn over the introduction of Dr. Morey to Dr. John Kurtz, who is one of Dr. Morey's early graduate students, and will undoubtedly say things that hopefully will not embarrass Les too much.
I'll do my best. It's a real honor to introduce today's master lecturer. And fortunately, you won't be long before you start hearing him because this is entirely impromptu, so coming straight off the cuff. The story I can tell about Les is when I was applying to graduate school and looking at a number of options for a PhD program in clinical psychology. The most compelling thing to go to Vanderbilt and study with Les was his current students. His current graduate students just said, he is the greatest guy. He's just a pleasure to work for. He's a wonderful, supportive mentor. And I thought, I've got a lot of other good options, but that's good enough for me. And still to this day, Les is truly one of my best friends, and he's a terrific mentor and a great influence on how I see personality and psychology.
Thanks. It's really nice to see my complimentary former students. And I appreciate the introduction as well as the invitation to come and talk. My talk is on DSM-5 and personality disorders, some observations on process and content. I will offer those observations having been a member of the Personality and Personality Disorders Work Group for DSM-5. This here on the slide is the work group membership list. It's straight from DSM-5. It has some very interesting and unique aspects to that membership list. To the best of my knowledge, it's the first membership list to appear in the DSM-5 that has a footnote, which explains that the membership of the group takes absolutely no responsibility for what happened. It's also the first to have, you'll notice here a few members that have years next to their name. I'd like to assure you that both are still alive to the best of my knowledge. So that does not indicate that they were deceased during the process, although there were a few threats in that direction. So it was an interesting process, and I'm just going to offer my observations on it. I want to make sure that you understand I'm not speaking for the work group. My observations are entirely personal. The other members of the work group no doubt would disagree with me, as was often the case in the process, and so these are really purely based a lot on my own research and my own observations. I'd also like to point out up here at the top of the slide, the DSM-5 is published by the American Psychiatric Association, whose headquarters are in Arlington, Virginia. And so the invitation to come back here, I recognize was a kind attempt by SPA to provide a little exposure therapy for me. I'd like to point out that exposure therapy is not an empirically supported treatment for DSM-related traumatic stress. So just to hedge my theoretical bets, I'm going to try a little ab reaction too, as well as exposure, and so I'm basically going to come up here and vent. And so that's what I told the board that's what I would do, and they said, oh, sure, that'll be fine. And so that's what's going to happen. And now before I go any further, just very briefly, I want to pay my respects to one of my predecessors on the DSM-3 and DSM-4 work groups, Ted Milan. Ted and I had a lot of interesting interactions over the years. I teased him a lot. He was extremely good-natured about that, actually a very generous individual with his time, and also very supportive of me. And I really think we can all agree that this field is going to be a lot less interesting without him around. But speaking of moving on to the next DSM, so what was the idea of DSM-5? There was hope at the beginning that DSM-5 would be a paradigm shift in the same way that DSM-III really had been. Basically, Bob Spitzer single-handedly brute forced DSM-III into being dramatically different from its predecessors, with a real focus on trying to increase reliability. The supposed goal of DSM-5, what we were told at the beginning, was that what would happen is that we would be a similar paradigm shift in the direction of validity. And we went to an initial meeting, all the work group members, the entire work group, there were 13 work groups, each of which were comprised of 10 to 12 members. The chairs of each of those work groups, as well as the leadership of the DSM-5, which were David Kupfer and Daryl Regier, formed the task force. And so we were told in a big meeting at the beginning of the process, everything's on the table. We want you to be thinking differently. We want you to be trying to make this the most valid instrument that you can. Everything's on the table, and if you want to do things entirely differently, then that's what we need you to do if that's what's needed for validity. It turned out one of the work groups took that seriously. And I'm not certain it worked quite as anticipated. Clearly, we went into it feeling that there were big problems with DSM-IV. They're well documented. I don't really want to spend a lot of time on them. Some of the big problems, comorbidity is a big issue because the typical person with a personality disorder meets criteria for more than one, so that it's the rule rather than the exception to have comorbidity, which confuses a great deal of things. Despite the comorbidity, there's still a high use of NOS, not otherwise specified diagnoses. And the distinction between where this category, begins and where it ends was always a little bit arbitrary. And basically, the rule seemed to be, well, if you had more than half of the criteria, then suddenly you were awarded membership in the borderline club or something like that. And if you had one fewer, well, you were fixed. And so that notion as to that's how personality dysfunction was organized, nobody really believed, including the people that derived the DSM-IV. So to try to figure out what the direction should be, just before the DSM-5 process started, an article by Bernstein et al. That surveyed two influential groups, ISSPD and ARPD, both of which are personality disorder research groups, surveyed the membership to try to get opinions on what the DSM-5 personality disorder section should look like. And the results of that, I think, are instructive. They're instructive in that they're not unanimous. Okay? There was not 100% agreement on anything. In fact, looking down here, 4% of the membership, now where's my little, come on, I used to have it. All right, I'll use this one. 4% of the membership felt they should just eliminate personality disorders entirely, maybe because they wanted to not pay dues to those organizations anymore. So, but in terms of how the DSM-5 should look, about a quarter, 25%, felt that it should be a categorical system, just like was at present in DSM-IV. 55% said it should be a purely dimensional system, that there shouldn't be any categories whatsoever. And 70% felt that it should be a hybrid system of categories and dimensions. I'd just like to point out in this table, the most widely held belief, about 77%, felt that personality disorder should stay on axis 2, separate from axis 1 disorders, which of course did not happen. And I'd also like to point out that had absolutely nothing to do with any decision that was made by the personality disorders group. They never asked us about that. We expressed no opinion on that. We were simply told, hey, sorry, no more multi-axial system. So if you want an explanation of that, you have to seek elsewhere, I'm afraid. Now, a lot of my thinking on the way that this particular hybrid system, which seemed to be the sort of consensus, to the extent that there was one, that DSM-5 should look like was driven by my experiences as a participant in the CLIPS project, Collaborative Longitudinal Personality Study, that followed people with personality disorders for 10 years. And in particular, my niche within the CLIPS project was to sort of compare alternative models of trying to represent personality disorders. And some of the conclusions from that can be found in this, where's my, geez. There's an article in Psych Medicine in 2012 if you want to try to read the specifics. But generally speaking, the conclusions were that a model of personality and personality problems that was represented by Leanna Clark's SNAP instrument, which stands for the Schedule for Non-Adaptive and Adaptive Personality. Okay? So it has both maladaptive and adaptive elements in it, that provides lower order pathological traits that can be arranged into a higher order sort of normative trait model that is basically represents Professor Tellegen,'s three-dimensional model of personality, and I know that he's here somewhere, or maybe not listening to me. Okay, sorry. But basically that model had better predictive validity than the DSM at every time point and on a variety of different outcome criteria. Now, that being said, the DSM-IV concepts did add something to that SNAP model. They did increment the predictive validity. The NEO-PI, which was also administered to participants in terms of how it was administered at baseline, didn't, which basically implied not that there was anything wrong with the NEO-PI, but to the extent that there was something about traits that was predictive of the future, it was pretty well captured by the model that was portrayed by the SNAP, which was in essence a combination of maladaptive and adaptive forms of dimensional personality traits. Yet the DSM added something above that model. And then finally, there was the finding that the predictive validity of the DSM-IV information was remarkably unidimensional. The coefficient alpha for the 79 diagnostic criteria in the DSM-IV at baseline in the CLIPS study was 0.94. Now, my former students and my current students know I'm not a big believer in coefficient alpha as being good or bad. It just simply is, and that is remarkably unidimensional with the coefficient alpha 0.94. And to further underline how unidimensional it is, a paper by Chris that was with the CLIPS data, Chris Hopwood, that was published in JPD in 2011, took a look at the predictive validity of that single number, 0 to 79, how many personality disorder criteria do you have? A single scale with a coefficient alpha of 0.94. And in the blue here, you can tell that most of the predictive validity for predicting the GAF, for predicting social functioning, work functioning, leisure functioning, and outcome was subsumed by that one number. And knowing the rest, knowing which criteria you had for which disorder, which personality disorder, mattered far less. It provided very little increment above just simply knowing, man, they got a lot of criteria. And so once you know that, you're learning something very important about the patients, but it's remarkably unidimensional. So based on those sort of findings, I was really okay with the initial model that was proposed, which is that the DSM-5 should present a representation of severity of personality pathology that tends to be shared across all personality disorders as a unidimensional phenomenon, that we capture problematic personality trait dimensions that have maladaptive variants but can be tied to normative trait models, and that we use that model as an amalgam to forge a hybrid that tells us how personality types exist in that space. And so that was the idea behind DSM-5. Okay? Seems logical, or at least it did to me. Unfortunately, most of the rest of the world did not share that opinion. The people, immediately started, having all sorts of nasty things to say. Alan Francis was, going ballistic. He's got his 19 worst suggestions for DSM-5. It's sort of like the NCAA bracket of DSM mistakes. And we didn't make the top 10, so I was kind of disappointed. The editorial in the American Journal of Psychiatry, signed by a number of people that presumably I would like to have felt better about this. One of them was a master lecturer last year here, Jonathan Shedler. Aaron Beck, people probably heard of him. Otto Kernberg, people probably heard of him. John Gunderson, my longtime collaborator and a co-author of all those CLIPS papers that I just pointed out to you, also said, well, this is a terrible idea, yet of course perfectly consistent with the data presented in articles that had his name on it. But so there were a lot of people that were skeptical of the model. So we made some revisions to the model in the face of some of the comments that people made and tried to move forward with it. Ultimately, we had 2 work group members resign. I'll talk more about that towards the end. But finally, we managed to get a model that was supported unanimously by the work group, and the work group was diverse. People were not from similar backgrounds. There were PhDs, there were MDs. During the process, the president of the American Psychiatric Association was on our work group, as well as a number of psychologists who were members of this organization. And so we had a very diverse group of people, yet we managed to have this model as a consensus that was supported unanimously by the group. We forwarded that model to the task force, who also had to vote, and they voted unanimously but quite grudgingly to endorse our model. We were also endorsed by the leadership of the DSM-5 committee, and then we went forward to the American Psychiatric Association Board of Trustees, where they rejected it, and they said, forget it, we don't like this, and they said nothing else. There was no reason was given. It's just simply no editorial reviews. They just basically said, no, we don't accept this. Instead, what we'll let you do is we'll put it in Section 3. And what we'll do in Section 2, which is where things like major depression and alcoholism, et cetera, appear, we'll just retain the DSM-IV criteria independent of multi-axial diagnosis. So what we have in the main body of the DSM-5 are the DSM-IV criteria. And the alternative model that I'm going to talk about that we proposed is now in Section 3. So what is Section 3? It's titled Emerging Measures and Models. Okay? There's, as you can see down here, see there we are, alternative DSM-5 model for personality disorders. And we're in here with an interesting cast of characters that were also equally, ideas that were cockamamie. For example, internet gaming disorder is down here with us. I have no clue what internet gaming disorder actually is. But it reminds me, just a second, I want to see how my guild is doing in this raid. Okay. 4%, okay. So they don't need me. So anyway, we're down here in Section 3, and we are trying to figure out how best to try to get that model maybe bumped up to Section 2 somewhere along the line. In the process of doing that presentation to the work group, to the task force, and to the Board of Trustees, I personally felt that there were some data that were really important for us to gather. I'm a very data-oriented guy. I'm really not terribly ideological, despite those of you who have heard me have formed the opinion that I have preferences among objective personality tests, for example. But for the most part, in terms of models, I really want to try to let the data be a guide as much as possible. And so I tried desperately to get data, right? So I wrote a grant proposal, sent it to our friends over across the way, got a fundable priority score, not bad, got sent to council, also across the river, and they said, we don't support DSM-5 research. That's the job of the American Psychiatric Association. They're the ones getting all the bucks for selling these poor SAPs DSM-5s. So we're not providing research funding. You want to do research on our doc, Morey, you come back. But don't come about the DSM-5. You ask the American Psychiatric Association for money. Well, I have no pride. I ask anybody for money. So I asked the American Psychiatric Association for money. And they said, nah, no, we don't want, like, scientists doing this stuff. We're going to have a centrally coordinated field trial that proved to be ultimately almost totally useless for personality disorders. Somehow, they funded a field trial and everybody with personality disorders vanished. They couldn't find anybody. I mean, all they could find were borderlines. And so when they implemented it in the field trials, actually borderline personality, to the chagrin of a lot of the people on the task force, ended up having one of the best inter-rater reliabilities in the entire DSM-5 field trial. And of course, they were quite skeptical of it, and yet the inter-rater reliability was quite good. But that's the only factoid that emerged from the DSM-5 field trials that was relevant to personality disorders. But I'm saying, but that's not what we need. There's other stuff we need. So ultimately, to try to get the project done, I turned to another funding source. My summer salary. So ultimately, I funded the participants, and I didn't take summer salary. So there you go. But I did. It shows you that I was serious. I mean, I really did want data. So I'm going to talk to you about the data that came out of that. It was a field study of the criteria. It was a web-based survey completed by 337 clinicians, about a third of whom were physicians, were psychiatrists, and about 60% or so were doctoral level psychologists with some other professions, MSWs, et cetera, worked in. About 50-50 the clinicians, men and women. I solicited them from email lists of numerous professional organizations, including Society for Personality Assessment. I know many of you participated, and I greatly appreciate it. You all got a $75 Amazon gift certificate for participating. I hope you got something good with it. I sent out about 1,800 emails. I have no idea how many bounced. The survey software couldn't track that. I have no idea how many spam filtered. All I know is that the email provided a link, say, here, click here to learn more about the study. 444 people clicked that link, and 337 ultimately completed the study, which was 76% of those that clicked and 18% of the initial emails. What I asked them to do is provide me with a formulation of a patient that they had seen for a minimum of 5 hours clinically. So I wanted them to know something about this person over time. Okay, so they had sort of repeated exposure to the person. Of those 337 patients they described, each one only describing one patient per clinician, 16% had no personality disorder. The most common PD in terms of the clinical DSM-IV diagnosis was 40% at borderline personality disorder. The instrument had 3 parts. The first part asked information, demographic information about the clinician and about the patient. Various clinical judgments about the patient were completed. I then asked, yes or no, did the patient meet the following criteria for DSM-IV, verbatim out of DSM-IV, for all 79 criteria, presented in random order. Okay? And then at the end of that, I said, okay, what's the DSM-IV diagnosis for this patient on personality disorders? And then following that, I asked them 6 questions having to do with how clinically useful they felt going through that process was. I then moved to the DSM-5, verbatim out of DSM-5, asked them about all DSM-5 criteria for the personality disorders. I had them assign the single item severity rating, the level of personality functioning rating, and then I had them make 4-point judgments of the 25 facets and the 5 higher order domains that were presented in the dimensional pathological trait model in DSM-5. And then following each one of those sections, the DSM-5 criteria, the level of personality functioning rating, and the dimensional trait assignments, I also had them make clinical utility judgments. And I counterbalanced whether or not DSM-IV or DSM-5 information was gathered first. So I want to go through the 3 different components of the model and tell you a little bit about the results. With respect to the severity or the level of personality disorder, which was represented by the level of personality functioning, the way that is set up is that the idea is that running through all of the personality disorders are key core dysfunctions, that those dysfunctions primarily manifest in the self and other representation domain. And what it leads to are problems in identity formation and coherence, problems in self-directedness, both of which are related to the self, and problems in interpersonal functioning that are represented in deficiencies in capacity for empathy and deficiencies in capacity for intimacy. And so the idea is that those characteristics are common to all PDs. All PDs, people with personality disorders, share those dysfunctions. So those are key personality functions. It's what we require to have successful personalities, and to the extent that you can't do it, then you have personality issues. What happens is a single rating describing problems in those four areas is to be made on a 5-point scale ranging from little to no problems to extreme problems. This contrasts with the DSM-IV, which doesn't really say what personality disorders have in common in any really clear or specific way. It's really hard to know exactly what a personality disorder is by looking at the DSM-IV criteria. There's no real clear specificity that makes it uniquely personality related, and there's no real clear way to assess what the core commonality is. They're just sort of say, well, there's problems somewhere, and they're kind of long-lasting. But we're saying, no, there are core dysfunctions. And if you have those dysfunctions, you got a personality disorder. And if you don't have them, well, you might have something else. Maybe you've got depression, but that depression doesn't necessarily impair your capacity for empathy. You don't have a personality disorder. You've got depression. Okay? So we're trying to articulate exactly what personality disorder is. Now, to try to help with that, a rating scale with anchor points is provided in something called the Level of Personality Functioning Scale. You can see here there's a lot of very small text, in here, okay? A lot of small text. You can't read it. There's a lot of words. I wish there were fewer words. I always was pushing for fewer words for the most part, but those words are there to provide an anchor point. Implicit in those words is that the dysfunctions that are represented in this level reflect failures in developmental or maturational processes. Okay? So the notion is that there's something developmental or maturationally going wrong. And I think that anybody who's had kids and raised them recognizes that these things have clear developmental trajectories. And if you've got a 5-year-old, you're going to find that they probably don't have a great deal of self-directedness, right? They don't have a great deal of identity of who they are. They don't have a really great capacity for empathy, or they're certainly not equipped to have intimate relationships at age 5. And maybe they're better at age 10. At age 15, they're maturing. At age 25, there's further maturation. You can see a clear developmental trajectory in those sorts of things. Now, of course, implying something like that is clearly heretical. It's never been proposed before. Nobody on earth has ever said anything like that. And so we were, castigated for pulling stuff out of thin air that was, heretofore unannounced. Well, of course, a lot of the people in these pictures suggested exactly this thing. The idea that there's a maturational continuum that's a core consideration for whether personality works or not. This is not a new idea. And to think that the level of theoretical and empirical support for this idea is like internet gaming disorder is like a level 1 night elf. It's just not very sophisticated. But the problem is say, okay, let's make these people the DSM-6 work group. Now, that would be difficult for a number of reasons. But one of the reasons it'd be very difficult is that all hell would break loose, all right? You put these people all in a room down the road in Arlington, Virginia, and come up with a consensus model of what the maturational continuum looks like. And of course, Freud attacks Jung, and then what happens is Maslow goes up the hierarchy, Rogers grows, Piaget's trying to assimilate Kohlberg. It'd be ugly. They won't agree. But I think we could all agree that every one of the people have really good and important ideas. And that certainly they would all share the notion that maturational continuum has to be represented. Anything that has the word personality in it in this freaking diagnostic manual, it has to be represented somewhere. But it isn't in DSM-IV. It isn't in there anywhere. But in my view, it needs to be. But there was some pushback on this notion. So I'm going to provide certain caricatures of various things that I heard over the years. One was by a high-ranking person in the American Psychiatric Association. You're going to make these clinicians use things like identity? They don't know what that is. They've never heard of that. I pointed out that it had been in the DSM since 1980. And so if they hadn't figured it out in the past 30 years, they probably weren't going to figure it out by now, but certainly they had plenty of previous opportunity to figure out exactly what identity is. Say, well, how are you going to, that doesn't show up on fMRIs, I think there's no glowing, stuff in the identity region. We don't have pills for identity improvement. And so these concepts, clinicians are never going to be able to use. These are not science concepts. So, well, of course, that was the idea of the surveys. Can clinicians use this? And so, again, I asked clinicians to make that 5-point rating scale, 1 to 5, little to none to extreme, how impaired in personality functioning is defined by those 4 areas, identity, self-directedness, empathy, and intimacy, how impaired is the individual? So everybody in that study rated that thing 1 to 5, single item scale. That single item scale had a 85% sensitivity and a 73% specificity for predicting whether or not a person met any one criteria for any of the personality disorders in DSM-IV. They did it with 1 item, okay? An area under the curve of 0.83. That's not a bad number if you hang around AUCs very much. That implies a fair amount of validity for determining whether or not a person has a personality disorder, and also suggested that being in the middle on that scale, moderate, kind of calibrates to what people are thinking about DSM-IV as being a personality disorder. I would also like to point out that I invite you to go home and calculate the coefficient alpha of that scale, because it would point out to you that coefficient alpha has absolutely nothing to do with whether or not you can establish validity, but I'll leave it at that. That single item also proved to be able to predict clinician ratings of psychosocial functioning as a composite of risk, as a composite of their prediction of risk, their prediction of the patient's prognosis, and their estimated level of care that the patient would optimally need for a successful outcome. In other words, what kind of a treatment assignment that should be. And as it turned out, that single item was as good as a regression model combining the 10 DSM-IV PDs in 3 of the 4 clinical judgments and 3 of the 4 criteria that I listed for validity. The single item was doing as good or better than the entire DSM-IV system. And in fact, in all 4, that single item incremented the DSM-IV valid variance. So a single item tells you a lot. And ultimately proof that severity rating, to me, is telling us something valid about these patients in the minds of clinicians who had no training and no prior experience with this at all, because this is before DSM-5 came out. It's probably the first time many people had seen this, right? No training, but that level of validity. So what about the next part of the model, the trait aspect, problematic traits? Basically, the way that this looks is that there are 25 lower order facets, and the idea was that these traits were designed to kind of to replace the criteria in the DSM-IV. So instead of 79 criteria, we would have 25 traits. And the idea was that those lower order traits could be combined into higher order domains with a proposed 5-dimensional structure for those higher order domains that bears resemblance to certain other 5-dimensional structure models that people have talked about over the years. And a number of presentations here have looked at research with the PID-5, which is a self-report instrument that gets at a lot of these problematic traits. In the DSM-5, Section 3, the definitions of each of those traits and domains are provided. Again, there's a lot of words. Again, implicit in describing these traits is a certain theoretical heritage. The notion that these traits probably represent temperamental and most likely biobehavioral individual differences, okay, at some level. And of course, there's no data in support of that. I mean, how heretical a concept that we can have a hierarchical trait model in the DSM. Nobody has ever proposed something like that before. It's clearly a unique idea. Well, of course, a number of people have proposed trait models before, have suggested they can be organized hierarchically. Many of them bear a great deal of resemblance to one another, but that doesn't mean that if I put these individuals on the DSM-6 committee and asked them to come up with a consolidated trait model, that they would agree. Of course, first thing would happen is that Ising and Cattell would go at one another, and then all hell would break loose. Again, there's agreement that we need to have a dimensional trait model to represent the core elements of personality, but there's not necessarily going to be agreement on specifically what that should look like. Well, the idea, though, is then, well, then which one do you pick? Well, then, of course, everybody said, well, what are you coming up with this new model for? You should be using Model X. You should be using Cattell's, Eysink's, Tellgin's, Costa-McRae's, Goldberg's. You should be using that one. But basically the idea is that, well, to a certain extent, if these represent natural phenomena, they'll come out. They'll come out in the data. And so we will recapture those models. If we have reasonably well-articulated trait descriptors, we're going to recapture those dimensions. And so the question is, well, can we recapture those dimensions if we start looking at these things using the traditional methods that people in this area do? So in a paper that appeared in Journal of Abnormal in 2013, I described a hierarchical factor analysis strategy using Lou Goldberg's Bass-Ackward strategy to develop a hierarchical structure. It was a direct replication of Aidan Wright's paper that appeared in 2012 with a couple of important differences. Aidan's paper was based upon non-clinical sample and was based upon the PID, which is a self-report inventory. Mine was based upon a clinical sample and was based upon clinician ratings of those characteristics. And so the question is, are we converging on anything that looks familiar with respect to dimensional trait models? And in fact, the dimensional structure, the hierarchical structure looks quite familiar. We basically break down at the first level between internalizing and externalizing. Anybody ever heard of that before? We then go to the third, the level of three factors. We have sort of externalizing negative affectivity and detachment, which sounds an awful lot like a various three-dimensional models that people have proposed. We go down to the five-factor level, and we see negative affect and psychoticism and detachment and compulsivity and sort of an externalizing disinhibition characteristic. All right. So for the most part, we are recovering structures that look awfully familiar in terms of these hierarchical dimensional models. And so how well did this correspond to what Aidan found using a different method and a different instrument? Okay? Not clinician ratings, but rather self-report. Well, looking at the congruence of the factor structure at the five-factor level, which is the proposed level that is described in the DSM-5 Section 3 model, 4 of the 5 higher order factors had an average congruence coefficient of 0.88. Right? That's out of 1. Right? That's a high number. Personality research doesn't see 0.88s a whole lot. This is different method, all right, and different instruments. The only one that was different really was the compulsivity dimension, which looks different in clinicians' minds, I think, than it does in the self-report world. And I believe that. For example, if you think about the concept of compulsivity and you try to think about, is that really the opposite of disinhibition? Well, the opposite of disinhibition is conscientiousness. It's high constraint. And compulsivity and constraint aren't the same thing. If you think of the term compulsive gambling, that's clearly not constraint. Right? To a certain extent, it's a lack of constraint. It's a failure of constraint. And so I don't think that the clinical concept of compulsivity maps well at all onto that. But again, there's more research to be done. But that's a relatively minor point. Right? The point is, we have, for most of these things, remarkably strong convergence across methods, that there's a hierarchical trait dimensional model that we can recover that looks a lot like models of normative personality. Now, the third component of the model is the types, the disorders themselves. Okay? Now, the DSM-IV has personality disorder types. That's basically the model. We have personality disorders. There are 10 personality disorders in DSM-IV. There were 2 personality disorders, passive-aggressive or negativistic, and depressive personality that were in an appendix. So basically the idea is that we've got these 10 to 12 sort of discrete representations of personality pathology. And I've made allusion to the historical grounding of both the importance of a core maturational continuum and of sort of a hierarchical dimensional trait relevance. Both of those have a long history in the psychology field, and I'd also like to point out that this approach has a long history as well. For many years, there's been the idea that there's roughly a dozen discrete personality types is in existence. You can find it in the zodiac. Where you actually, in a lot of ways, it's superior to the DSM-IV. It has a very nice, it has a very nice circumplex structure, as Aaron pointed out this morning, and it has very little comorbidity, unless if you're on the cusp point, there might be. Okay, So there's a historical precedent for this approach. Now, the DSM-5 approach proposes criteria for 7 PD types, or 7 PD disorders. Borderline, antisocial, schizotypal, avoidant, obsessive compulsive. Narcissistic was reinstated after a considerable controversy about its exclusion. It flew into a rage and said, "I'm too important to be deleted." And then we have the trait specified and no NOS. In other words, here's how you specify a personality disorder that doesn't meet one of these other criteria. And if it doesn't meet those criteria, it ain't a personality disorder. Okay? So that's kind of new. And these types reflect a hybrid of that global personality pathology we talked about and these problematic traits. So in all of the criteria for personality disorders, and these personality disorder types, there's an A criterion which describes how it meets the core elements of identity, self-direction, empathy, and intimacy, and the notion that there have to be noticeable, clinically important impairments in at least 2 of the 4 of those areas. And then, in criterion B, is an articulation of what the trait combination is that maps onto that particular diagnostic category. So these are the criteria for borderline. The print's very small. I invite you to look back in the back section of your DSM-5s. Look at the criteria for borderline personality and tell me they don't look familiar. Okay? I don't think you're going to be terribly surprised by anything that you see. However, it got a lot of pushback. And this is probably maybe the most controversial element of things. And there's a variety of critiques, and I'll try to talk about them one at a time. You've eliminated the best diagnosis ever. My favorite one, you pulled it out. I actually like schizoid, and I felt kind of bad about schizoid going, personally, but nobody else did. So how do you make that decision? Well, this was a really important topic and a lot of argument. Every freaking meeting, the same argument. I mean, for a while at least. So why keep any of them? Why keep them around? Well, interestingly enough, I was probably one of the more active people advocating keeping them around. Right? Why? Well, because it's important to have some continuity for clinical use because that's what people have been trained on. There's a research base on these things, and there's starting to be an evolution of empirically supported treatments for some of these things, and so we need to have treatment resources to be able to deal with some of these because there's significant, clinically important, prevalent, and impairing problems that last a long time and have high social cost. So we can't lose that information. Right? Thing is, we have to ascertain just how good is that research base, and does it really tell us do these diagnoses tell us anything beyond what a trait model would tell us? Do they tell us anything beyond what those dimensions are going to provide for us? Well, to get an idea of the adequacy of the research base, I went to my old buddy, the Science Citation Index, and plugged in each personality disorder, so borderline personality disorder in quotes, so I would get exact hits on that concept. And same for all of the DSM-IV PDs between 1994 and 2010, which is when I was trying to make these decisions about DSM-5. And you'll notice this looks a lot like a scree plot. Okay? The first column is borderline, and the second column is antisocial, the third column schizotypal, and that's avoidant, that's obsessive compulsive, and that's narcissistic. Now it's interesting, this follows in the order exactly that we recommended what things should be retained. But you notice in terms of a really good research base, there's not that much research on an awful lot of these diagnostic entities. And clearly most of it ends up being on borderline, and antisocial and schizotypal being sort of the next thing, and a pretty good sized drop off after that. So I would almost argue what we got here is maybe a 3-factor solution according to the scree plot. And so if there's, in terms of a really adequate research base, I would say, well, we got a pretty decent research base on 3 of these things. I'm not so sure about the rest. But what about incremental validity? So if we look at the CLIPS data and say, well, can we predict GAF, which is global functioning, from knowing the person's DSM-IV personality disorder diagnosis above and beyond pathological traits? Does it tell us anything more? Okay? So what I did in this study, and again, this was in the Psych Medicine 2012, is did a conjoint factor analysis of the NEO and the SNAP. So extracted a domain-level structure of pathological traits, and then said, well, individually, can each one of the DSM-IV PDs tell us something more than that? Does it have incremental validity beyond that? Is there surplus information that we need to retain in DSM-5? There were only 3 diagnoses that appeared to add surplus meaning, surplus validity, incremental validity, at every time point in the CLIP study. Those 3 were borderline, antisocial, and schizotypal. The exact same top 3 that we saw in the literature. The 4th best actually was schizoid, my little buddy schizoid. He's still up in my room. He actually made an appearance in terms of incremental validity with respect to, for example, in these 6 different time periods. That was incremental validity in 5 of them. And I have a feeling that what Asperger's kind of went away, in DSM-IV, but I think schizoid actually kind of captured that to a certain extent, and I think it actually does tell us something, but that's a different story. But basically the idea is that I think that we can make an argument that not that many of them convey incremental information beyond if we provide people with a dimensional trait model, but some of them do, okay? And then finally, there's no such thing as NOS anymore. If your favorite one isn't in here, you can construct it, all right? The idea is that now we have a finite taxonomy of traits that you can pick from to describe what the person looks like. Basically, to have a PD that represents this trait specified designator, again, they have to have impairment in the core areas, 2 or more of those core areas, and then you describe 1 or more pathological domains in which those problems manifest. And so you can, and I did with my data, construct rules for all of the existing DSM-IV and your favorite DSM-3R and DSM-3 criteria disorders that might have gone away as well. So all of those things are still represented in there. Well, what about, you've changed the meaning. These borderline criteria don't look at all like my favorite borderline criteria that were in the DSM-IV. Well, the idea of having the survey data is I could tell you exactly how closely they mapped, right? And so having those data, I had, for example, these are the rules for avoidant personality. Up here, we have a prevalence rate in my sample for avoidant of 26.3% under DSM-IV criteria. And then I can tell you, well, looking at different combination rules, what are these things going to look like with different rules? How is the prevalence going to be affected by using different combinational rules of these traits and how many of these traits should be present and which ones should be present? I can also tell you what the correspondence would be with DSM-IV. I could tell you what the discriminant validity would be relative to avoidant compared to all of the other PDs to try to improve this problem with comorbidity. And I could try to relate it to increasing gaps in functioning, such as the idea that people that were above and below the threshold, actually it made a difference in their level of functioning, and that difference was larger at different thresholds. In other words, an empirically guided selection of diagnostic thresholds, not just, oh, they got roughly more than half of the list that I managed to concoct, but rather there's some logic as to why these thresholds are being selected. Ultimately, these are the prevalence rates of DSM-IV in my survey data. These are the final criteria you'll find in the DSM-5. These are the prevalence rates as to how things compare. Here's the kappa correspondence between DSM-IV and DSM-5. You might look at those kappas and say, wait, that's not perfect. See, you changed the meaning. Well, it turns out I did this before. This is, a repetition compulsion. I did this when DSM-3 moved to 3R. Published an article in American Journal of Psychiatry in 1988 on what the effect was of making that transition. And here's the kappa correspondences between DSM-3 and DSM-3R. Some of those kappas were not statistically significant. Okay? So that schizoid wasn't even significantly associated with one another between DSM-3 and 3R, whereas all of these kappas are statistically significant. And what do the average kappas look like? Well, in 3 to 3R, the average kappa was 0.51 with a fair amount of variability. In DSM-4 to 5 transition, the average kappa was 0.541. So I would argue that this this changeover, this change is not any larger than what we saw in moving from DSM-3 to 3R. And I don't remember anybody, I was there at the time. I don't remember people complaining about, oh my God, this is terrible, when people went from DSM-3 to 3R. Now on the other side, there's the people who said, why do you have these things at all? Why have any diagnoses? You're continuing to reify theoretical fictions. Okay? Why do you keep these things in there at all? Well, one reason is the fact is they have incremental validity. But why? Why do they have incremental validity? If the traits and the global level are capturing predictive variance, why is there incremental validity? And the reason is that these regression models that are in this picture, these are multiple regression models with no interactions, right? But what's happening is that some of these disorders are reflecting constellations or combinations of these traits and this global pathology dimension interaction. And so the reason it's surplus is you're starting to specify particular combinations, particular regions of the space. And so the reason it's important to keep those things in there is because we're starting to learn about what it looks like to have somebody who's high in personality dysfunction and high in disinhibition and high in negative affectivity, because that's what borderline personality is. That combination of things is something we know about because we got a bunch of research articles on that topic, all right? And so that's why those things in interaction are important to represent. And the argument I would make is that the concept of Chicago is a reasonable one and different from the concept of Milwaukee, despite the fact that it's simply a basic longitudinal difference between the two, right? You know, but they're different cities. They're surplus meeting to just the longitude and latitude coordinates. It means something to say, I'm from Chicago versus I'm from Milwaukee. You understand what the difference is. And so what's happening is that we have a coordinate space, but the advantage of having the types in there is we've started to articulate what it means to be in certain regions of that space. All right, okay, enough of that stuff. But you're vandalizing time-honored categories, and we follow these things religiously in our practice. Well, back in my previous study, back in the 1980s with Elizabeth Ochoa, I published an article that gets cited like once a decade that point out that actually the clinicians didn't actually follow the DSM-3 criteria very well. Right? They, you know, and how did I know that? Well, because I had the clinicians in that study indicate presence or absence on every DSM-3 criterion, and then I had them assign a diagnosis. But I could calculate the diagnosis from the criteria. They provided the information on the criteria. They provided the information on the diagnosis, but they didn't match. And in fact, sometimes they weren't statistically significantly associated. All right? So clinicians didn't really seem to be using the criteria. They assigned a diagnosis of narcissistic personality about twice as often as the patient met criteria. They assigned schizotypal about 8 times less than they said it met the criteria. So clearly they weren't following the criteria. Now you would think since the criteria look a lot like DSM-3, it's been kind of the same really since 1980, that people might have gotten better. Okay? Well, of course I could do the same thing in this study. Okay? The good news is that all the kappas are now significant. So you're getting better. The bad news is they're not that high. Okay? So the basic upshot is that basically about 12% of the decisions that clinicians make don't match the DSM criteria. Okay? So every time you make a DSM-IV diagnosis with the 10 main disorders, that's 10 of them. Odds are, one of those 10, you're wrong. What you think about the criteria doesn't match what you think about the diagnosis. Now, it turns out that the number of cases with no errors got a little bit better. But they're both kind of low, all right? So basically what ends up happening is that the number of times that a case matches perfectly is still less than half, okay? Odds are, I'll bet you, any patient you can think of, you make a checklist of the criteria that are in DSM-IV, and then I ask you what the diagnosis is. Somewhere in there, there's going to be a discrepancy. So if this is such a great system, how come people aren't following it a little bit more closely? And how come they haven't learned it better in the past 30 years? All right, enough facts. You know, we're in Washington. it's okay, you got a bunch of numbers, but clinicians are going to hate this complexity. They're never going to be able to learn it. It's too complicated. They're never going to use it. Well, remember those clinical utility questions that I asked? Okay? How easy is it to apply these concepts? How useful are these concepts to communicate with other professionals? All of these questions were extracted verbatim from an article by Samuel and Whittaker that was in 2005 Journal of Abnormal. 6 characteristics of clinical utility. And I compared the DSM-IV to the DSM-5, clinician-rated clinical utility, 1 to 5, 5 being very useful, 1 being not at all useful. Basically what I found is that with respect to being easy to apply and being useful to communicate to other professionals, the DSM-IV did okay. Right? The DSM-IV was seen as more easy to use than DSM-5 level rating, the global severity dimension, and the DSM-5 type criteria. And presumably it was easier because clinicians are much more familiar with it. And they also felt to be more useful for communicating to other professionals because other professionals probably would have heard of the DSM-IV. And the DSM-5 was new at the time. So DSM-IV was rated as better than DSM-5 for communicating with other professionals at that time. Every other number in this table favors the DSM-5 components over the DSM-IV. And in fact, the pathological trait ratings on all 6 utility characteristics were statistically significantly better than DSM-IV clinical utility ratings. Right? So the pathological traits, which were the newest and the most revolutionary and controversial aspect of things, the clinicians out there, 1/3 of whom were psychiatrists, and by the way, we obtained this difference across both psychiatrists and non-psychiatrists, the pathological traits were seen as more clinically useful in every respect than the DSM-IV. So it didn't seem that the clinicians minded using it either. So to come back, we had 2 resignations. You can read from Livesley and from John Livesley and Rohel Verhoel, both of whom published articles with their description of their reasoning behind this. I would encourage you both to read those articles carefully, because I just want you to understand that those resignations were for diametrically opposite reasons. It's not as if there was a concerted subgroup that felt that they were being dismissed. They had opposite views. All right. Livesley basically felt that there shouldn't be any personality disorder types at all, and Verhoel felt that the changes were way too dramatic and we needed to keep things closer to DSM-IV. Right? Diametrically opposite, representing the disagreements that we saw in that survey that was published in 2007. And then Livesley makes certain comments about things as being the model is inconsistent, incoherent, impractical, incompatible with empirical facts. Right? But the funny thing is that Livesley's got 2 instruments that he uses. He's got the GAPD, which measures general personality pathology, divided into self and other problems, which an article in 2013 JPA indicates as unifactorial, reflecting general personality dimension. And he's got a hierarchical trait model in his instrument called the DAP, which has lower order traits that can be combined into 4 higher order dimensions that look like my 4-factor solution, with the exception of psychoticism, which is not tapped by the DAP. So the funny thing is of everybody who's written in the world on this topic, that DSM-5 model looks no more like anybody's writings more than John Livesley's, and he quit. All right? So what's the deal, What is the deal? Basically, the problem here is that we can't get 100% agreement. We're never going to get 100% agreement, particularly if everybody says, well, I've got a model and it's the best and we have to adopt it. All right? If we're going to do that, we should have a 1-person committee. All right? And just like Spitzer, through brute force, implement those changes. So who should that committee be for DSM-6? And here's who it should be. It should be an amalgamation of every one of those pictures I showed you before, because there's no one person I would trust to do it. All right? I particularly love Eysenck morphing into Freud. He's spinning. I can hear him spinning in his grave. And Auke, actually, you and Carl Rogers morph really, really nicely here. So that's the only way I think we would get 100% consensus, is have a 1-person committee, and to get a really good model, we really need to have a person who represents the best characteristics of all of these formidable individuals. Alternatively, We could just replace the whole damn DSM-5 with it has a lot of nice ancillary products. But the trouble is we got to get past that, you know? We got to get past this sort of approach to the world. And, you know, so I am being, you know, partially facetious about that. But in closing, I really want to say that I don't know what the DSM-6 model is going to look like, but my view is that it's got to reflect severity, providing a specific conceptualization as to what personality disorder really is, because a lot of our predictive information comes from that. We need to describe problematic traits because they provide precision in describing the different variants. They also provide a lot of predictive information. We need to describe types because it provides continuity with our existing research base. And that research base is starting to characterize the characteristics of existing regions in that trait space that we've articulated with this model. And in doing so, by describing these dysfunctions and these trait structures, I think we're going to have better targets for etiological research and for treatment research because it's starting to disaggregate some of the developmental influences and maybe some of the temperamental influences on what shapes personality disorders. And the DSM-IV sure as hell doesn't do that. All right? Because we got to get past this, well, hey, listen, I know what this model is and it's the best one. Ultimately, it's going to be a consensus and it's not going to be something that's going to please everybody. But if we can't get past that, I've seen the future. It looks a lot like the past. Thank you.
Thank you very much, Dr. Morey, for a very provocative and entertaining talk, giving us a lot to think about. So I'm sure everybody wants to get ready for their next sessions and have a little time before that. So I'll let you on your way.